Okay, Assalamualaikum warahmatullahi wabarakatuh. For the first, let me introduce myself. My name is Julia Daniati, with name 3011021001112 from MAP2. Here I am will present my journal entitled Randomized Control Trial of Vitamin D Supplementation in Older People to Optimize Bone Health. First, we discuss about abstract 1B. For abstract, vitamin D insufficiency is common in older people and may lead to increased bone receptions, bone loss, and increased falls and fractures. However, clinical trials assessing the effects of vitamin D supplementation on bone mineral density or BMD have yielded conflicting results. For objective, the study examined the effect of vitamin D supplementation on BMD at the hip using dual energy X-ray absorptiometry. For methods, a total of 379 adult age bigger than 70 years, 48% women mean age 75 years. For the nutheads of England were randomly allocated to one of 3 doses of vitamin D3, 12,000 international units, 24,000 international units, or 48,000 IU, given once a month. The primary outcomes was change in the MD at the hip. Secondary endpoint comprised the dose effect on femoral neck BMD, pulse circulation, calciotropic hormones, bone Turner's markers, and adverse events. For results, the men more or less HD baseline plasma 25 hydroxystamin D, 25 OHD concentration of was 20.0 more or less 20.1 and more or all, which increased after 12 MO to a mean 25 OHD of 25.9, 64.6 or 79.0 and more L for participants receiving a monthly dose of 12,000, 44,000 or 24,000 or 48,000 IU, respectively. There was no between group difference in BMD. However, parathyroid hormone concentration decreased in all 3 groups, with a significantly greater decrease in the 40,000 IU groups compared with the 12,000 IU groups. There were no difference in any adverse event between groups, with 3 cases of hypercalcemia known of nephrotiliasis and 249 pulse observed. For conclusion, there was no difference in chest BMD over 12 between the 3 doses of vitamin D, suggesting no effect of intervention on a similar attenuation of the anticipated decrease in BMD over 12 MO. The treatment was safe and effective in increased plasma 25 OHD concentration with no dose-related adverse event. For the next, background and objective 2A, introduction. Vitamin D insufficiency is common in older people and may lead to increased bone receptions, bone loss, impairment of muscle function, and increased risk of falls and fractures. The result of clinical trials assessing the effect of vitamin D supplementation on bone mineral density or BMD, bone loss, falls, and fractures have yielded conflicting results and although the recent meta-analysis of clinical trials report a possible relation between vitamin D supplementation and higher BMD at the neck of femur. It suggests that supplementation with vitamin D has a benefit for bone health only in those areas of vitamin D deficiency. And the next trial design 3A for methods, the vitamin D supplementation in older people trial was a single center parallel group participant randomized double-blind interventional trial testing the effect on PMD of 3 doses 300, 600 and 1200 UG or 12,000, 40, 24,000 and 48,000 IU of oral vitamin D given each month to men and women aged bigger than 70 years for 1 year as described earlier, with the first dose given between November 2012 and May 2012 and May 2013. For the next 4A, participants already taking element calcium supplements or vitamin supplements in equivalent daily doses of smaller than 500 mg and 10 UG or 400 IU, respectively, were allowed to continue their supplement. All participants provided written informed consent. A favorable opinion was obtained for the time and were such research ethics committees with research and development approval from the sponsor Newcastle upon Tyne Hospital and NHS Foundation Trust. For B, a total of 379 participants were recruited between November 2012 and May 3 and 2013. The first visit was on 8 November 2012 and the last visit was on 6 Jan 2014. For intervention 5, participants were randomly assigned in a ratio of 1:1 and 2:1 to 1 of 3 doses of vitamin D3 taken orally each month for 1 year. A computer generation allocation list of random permit blocks was used to ensure concurrent of allocation to subjects and investigators. Emergency code break envelopes were returned at the trial pharmacy, but no code breaking was recorded during the study. The medications were identical in appearance to the neither participant nor investigator was aware of the test given. For the next measurement, BMD at the total hip and neck of femur was measured using the energy X-ray absorptiometry or lunar IDXA GA heart care at baseline and at 12 MO. The scanner was calibrated daily before participant scanning. Daily phantom measurements were performed and present on repeat measurement was 0.21% with no perceptible drive for the duration of the study. Height and weight were measured and body composition was determined by bioelectrical impedance with a Tanita analyzer or Tanita curve. Fracture risk and self-report pulse history were obtained at the baseline, adapted from standard clinical care question and the FRAX tool. For the next participant involvement in the study. At the design phase, the research team discussed the intention of the study, the research question and measurement, and burden to participants with a representation of group of older adults with arthro, the Pond Clinic, Fremont Hospital. There were also 2 lay members on the trial steering group. At the end of the study, the newsletter was sent to all participants outlining the result of the study, and the research team answered calls from interested participants. There was no formal assessment of the burden of the intervention on healthcare workload during the study, but we did collect data on functional outcomes and quality of life are not included in primary analysis and yet to be analysis. For the results, a total of 379 participants were equipped with 343 or 91% participants completing the study at 12 MO. For the next participant from 13H A. Baseline characteristics including anthropometric parameters, ratios of calcium and vitamin D metabolism and intakes, renal function falls and major osteoporotic or hip fracture risks were well balanced across the 3 arms. There was also no difference in self-report habitual sun exposure between the 3 arms at baseline. There were no difference between arms in subsequent dropout from the study. The mean more or less as the baseline 25 OHD concentration was 20.0, more or less 20.1 and more or less. There was no significant difference between R4 change in BMD at the total hip site comparing 12,000 IU with 24,000 IU or P 0.39 or with 48,000 IU or P 0.0H. At the femoral necks, there was no significant difference between 20,000 and 12,000 and 24,000 IU or 48,000 IU. However, after 12 MO, there was significant group difference between up from change in plasma 25 OHD for at 12 MO. PTH was lower than at baseline for all dosage, with a significant difference in the decrease in PTH over 12 MO between 12,000 and 48,000 IU, but between 12,000 and 44,000 and 24,000 IU. For the next limitation 20 discussion, for the quest discussion, there was no significant dose effect on BMD at the total femur or neck or femur when giving a monthly dose of 12,000 and 24,000 or 48,000 IU vitamin D. This is equivalent to a daily dose of 10, 20, or 40 UG or 400, 800, and 1,600 IU, respectively. The primary objective of this study was to evaluate the dose effect of vitamin D supplementation on the attenuation of the age-associated decline in BMD, and our result complement a recent meta-analysis by Red et al., which conclude that there was no clinical significant effect of vitamin D supplementation on BMD, although that study showed a 0.8% greater BMD at the neck of femur over a mean study duration of 2 years. A more recent study, not included in red arrow meta-analysis, shows a significant effect of vitamin D supplementation on total BMD at a dose of 25 UG or 1000 IU, but not at 10 UG for 100 IU or D when compared with placebo. Of note, the latter study performed in Aberdeen, United Kingdom, requires a younger population than ours, mean age 65 years, comprising only women who also had a lower mean serum 25 OHD concentration at baseline 34 nmol or L. However, it is difficult to compare the result of either the meta-analysis of the Aberdeen study with the FDOP because both evaluate the effect of vitamin D compared with placebo, where the FDOP was a dose-ranging study with the 10 UG or 400 IU or the equivalent dose as different. Okay, well, so many presentation from me, more and less apologies. Wassalamualaikum warahmatullahi wabarakatuh.